Good afternoon, respected faculties. Today I am going to present a journal in the topic of role of therapeutic plasma exchange in yellow phosphorus poisoning. Myself, Dr. Arvind, Junior Resident, Department of IHBT, MGMMC Medical College, and my moderator for this topic is Dr. Sachin Sharma Sir, Associate Professor, Department of IHBT and MGMMC Medical College, Indore. I took this journal from Asian Journal of Transfusion Science, Editor-in-Chief, Dr. Jayashree Sharma Ma'am. It is a semi-annual magazine, Impact Factor 0.6, Volume 17, time period between January to June 2023, issue 1, page number 74 to 78. The chief editor for this, Professor Jayashree Sharma Ma'am, Professor and Head of the Department Transfusion Medicine, Chem Hospital, Mumbai. And the co-editors are Professor Rathiram Sharma, PGH Chandigarh, and Associate Professor Dr. Dheeraj Ketan from Lucknow. And this is an article I am going to present. Role of therapeutic plasma exchange in rat killer yellow phosphorus poisoning, which was carried out by Krishnamurthy Radhakrishnan, Ravindra Prasad Tokla, Ashwin Anandan, Chandran Srinivasan Rangan, conducted in Department of Transfusion Medicine, Sri Ramachandra Medical University, Chennai, Tamil Nadu, published on September 2022. Let us move on to the topic. Introduction. Yellow phosphorus is one of the rodenticide available. This is a potent hepatotoxin and it is fatal. Management of yellow phosphorus poisoning is difficult and no antidote is available till now, and only definitive management is liver transplantation. Our role in this yellow phosphorus poisoning, removing it helps the poisoning patients by removing the poison or its metabolites or the inflammatory mediators released in the body in response to toxin. Aim of the study is to determine the role of TPE in rat killer poisoning. Subject, the period of study between November 2018 to September 2020. Total 6 patients were included in the study period. 16 patients were included in the study period. And inclusion criteria, who are ingested rat killer poisoning as a paste, which contains yellow phosphorus, it is a hepatotoxin. And for the exclusion criteria, patient who had orally ingested rat killer poison in the cake form, which contains a different component, bromadiolone, which is chemotoxin. And patient who had exposed to the yellow phosphorus other than the ingested form, example skin exposure or gas exposure, they are excluded in this criteria. All the patients who had consumed other poisons and patients who were less than 18 years of age are excluded in this criteria. And methodology. First, initial evaluation was done by the treating physician, and then the request for carrying out TP was received in the transfusion medicine department. All of the TP sessions were done by central venous double lumen HD catheter. Because of the vascular access, we need in TP procedures requires high blood flow rate. So vascular access is very important for us because the veins should be rigid so that the veins should not collapse during negative pressure, during withdrawal and during inspiration. And acid citrate dextrose was the choice of anticoagulation for us. Acid is used in apheresis procedure to prevent blood clots during tubing inside the apheresis kit and its tubing. ACD does not cause systemic anticoagulation unlike heparin. And one disadvantage is there in citrate dextro in ACD solution, citrate toxicity. How to overcome that? We can use 10 ml of 10%. Citrates prevents the coagulation by binding to the calcium and involves in the coagulation cascade. It leads to hypocalcemia. So to overcome that, 10 ml of 10% calcium gluconate in 100 ml NS was administered as a continuous drip over 1 hour for all patients during the TP procedure. What are all the replacement fluids we are using? 5% human albumin, fresh frozen plasma and normal saline. Different proportion of replacement fluids were used in the study based on the patient coagulation status, albumin level and hematocrit. This study was carried out using complex cell separator by Fresenius Kabi. A specialized kit PL1 was used to perform this TP procedure. One plasma volume exchange was planned in all cases, but depend on the patient clinical condition and lab values. The number of plasma volume exchange varied from 1 to more than 1.4 in this study. And age and sex distribution of the patients in this study. Age between 18 to 30 years of age, 3 males were included and 4 males were included in this study. In the middle age group, 31 to 40, one male was included, and 41 to 50 years, 3 male were included in this study, and more than 50 years, 4 male and 1 female were included. Total 11 male and 5 females were included in this study. Discussion. The present study was conducted to evaluate the efficacy of TPE in case of yellow phosphorus rodenticide poisoning. Yellow phosphorus is readily available rodenticide in the market, which does not have any restriction to purchase. So, is an accidental ingestion among the children, and management of yellow phosphorus poisoning is difficult as there is no antidote available. And one of the study, Frank A. Simon and Larry K. Pickering were one of the very first authors in the literature to report the cases of yellow phosphorus poisoning. They reported 3 cases with acute toxicity symptoms. Patient initially present with oral burns, nausea, vomiting, and intense abdominal pain. In this study, 11 patients were presented with nausea and vomiting, 8 patients presented with abdominal pain, and 4 with icterus, and 3 patients presented with altered sensorium. Most of them are presented with GI symptoms, and very few are presented with neurological symptoms. And the second study was conducted by Macaron et al. The authors report that 53% of patients present with initial symptoms of vomiting and abdominal pain. 28% of patients had irritability, stupor, coma, and flapping tremors. 19% of patients were present with mixture of GI and neurological symptoms at the time of presentation. When comparing with this study, the most common symptom was nausea and vomiting, which was noted in 11 patients. There were only 3 patients presented with neurological manifestation at the time of admission at our center. And the third one, which was conducted in Philippines among the firecracker workers who consumed firecracker, the authors observed the symptoms and progress of the acute hepatotoxicity. They noticed at least 9 patients in their study had jaundice within 48 hours after consumption. In this study, all of the 16 patients presented with total and direct bilirubin elevated at the time of admission to the hospital. Because of the lag time, it worsened the liver function. And the fourth one, Smita Bhatt and Kumar P. Conchetti studied the role of N-acetylcysteine in case of yellow phosphorus poisoning in their case study. Out of 100 rodenticide patients, 27 patients were treated with NAC. Among the patients, 19 were recovered, 2 were died, and 5 were discharged against medical advice. In comparison with our study, all the 16 patients who received TP also received NAC soon after admission into the hospital. In our study, the mean hospital stay was 11.4 days. The total bilirubin at the time of admission was 14.7 gram per deciliter, was reduced to 3.5 gram per deciliter, 3.5 gram after consecutive TP sessions, and it is statistically significant. And the mean direct bilirubin value at the time of admission was 9.66. At the time of discharge, it was reduced to 2.04 after TP sessions. This one also there was a statistical significance. And the liver profile AST at the time of admission was 1000 to 1023.6, and at the time of discharge it was reduced to normal range 51.8. This one also shows a statistical significance. And ALT at the time of admission was 346.38, and at the time of discharge it was reduced to 44 international units per liter. This one also has a statistical significance. And coagulation profiles. The mean value of coagulation profile at the time of admission was 40.35. It was reduced to 24.7. It also shows the statistical significance. At the time of admission, prothrombin time was 42.15. At the time of discharge, it was reduced to 12.06. After consecutive TP sessions, it also shows statistical significance. In our study, a total of 48 sessions of TPE were performed in 16 patients. Among the 15 patients, between 1 to 1.2 volume, 23 sessions were performed. Between 1.3 and 1.4, 12 sessions were performed. More than 1.4 volume was exchanged in 13 sessions. One patient received one session of TP and one patient received only one session. One patient received 6 sessions of TP and one patient received only one session of TP, with most number of patients receiving 3 sessions. 7 patients receiving 3 sessions of TP. The authors noted that there was statistically significant improvement in liver function test and coagulation profile, p-value less than 0.05. This was comparable with our study. And what we concluded in this study, we observed that TP could potentially bring down the symptoms caused by yellow phosphorus toxicity and bridge the gap between medical management and liver transplantation. And this is the picture of ratol in the paste form, which is easily available and accidentally ingested by among our children. Difference between rat paste and rat cake: brand is different and the principal component for rat paste is yellow phosphorus and for rat cake is warfarin. Rat paste is direct toxic and vasculotoxic, and for rat cake it involves in the coagulation cascade. Antidote is not available in rat paste, and vitamin K is an antidote for rat cake. Yellow phosphorus is a highly toxic inorganic element that is mainly used in firecrackers. In 19th century, it was mostly used in friction matches, and it is evolved into crackers, ammunition like bullet tracers, bombs, fertilizers, and rodenticide. It has a garlic-like odor. It also called as white phosphorus. When it exposed to air, it becomes white fumes. As there is an emerging resistance to conventional rodenticides, yellow phosphorus is now being used as a rodenticide in form of paste. So, since it is a paste formulation, there is an increased chance of accidental poisoning, particularly among the children. Toxicity: intoxication occurs with suicidal or accidental ingestion. It is easily absorbed through GAT, mucosal surface, and even through skin. It is widely distributed through the body tissues, especially at the liver. The peak level is reached occurs after 2 to 3 hours of ingestion. The toxic dose is 15 microgram and the fatal dose is more than 50 milligram. 1 milligram per kg body weight. What is the mechanism of action of yellow phosphorus? It is a protoplasmic toxin. Protoplasmic toxin means it involves in the cellular level. It disrupts the ribosome. It disrupts the membrane integrity, and it causes multi-organ failure, particularly cardiac, hepatic, and renal functions. The toxic effect is mainly due to alteration that occurs in the ribosomal function, leads to altered protein synthesis. It involves in the lipid peroxidation also, and it also causes dysregulation of blood sugar and glycogen deposits. It affects the lipoprotein synthesis and the secretion of triglycerides, causing fatty degeneration of multiple organs. Clinical features are categorized into 3 phases. First one is initial phase. It occurs within 24 hours. After that, latent phase. Latent phase is an asymptomatic stage. Latent phase between 24 to 72 hours. And the last one is toxic phase. It otherwise called as advanced stage after 72 hours, more than 72 hours. Stage of general symptoms. Mostly it carried out GI symptoms only: abdominal pain, nausea, vomiting, diarrhea, and fever. Apart from this clinical symptom, patient doesn't have any abnormalities that can be detected by means of lab investigations. Asymptomatic stage, it present between 24 to 72 hours. The patient seems to be well preserved and has no symptoms during this stage, but there will be a mild elevation of bilirubin and liver enzymes with demonstrable histological changes suggestive of toxic hepatitis. There is a stage where the patient may be discharged from the hospital with symptom free. Advanced stages after 3 days of poisoning until the patient recover or death. Clinical feature present as hypotension, tachycardia, arrhythmia, cardiogenic shock. In GI, acute fulminant hepatitis, hepatic encephalopathy present with altered sensorium, confusion, drowsiness, and flapping tremor, stupor, coma, and coagulopathy. In CNS, confusion, hallucination, psychosis, irritability, uh, and the last acute tubular necrosis and anuric renal failure. Depend on the amount of yellow phosphorus ingested, some patients recover spontaneously. The reason for spontaneous recovery is unknown. Some patients develop oliguria and it causes acute tubular necrosis, results in renal failure. How to manage skin decontamination, supportive management, and gastric lavage. As yellow phosphorus can be absorbed across the skin, all the particles can be washed off with water. Supportive management, airway secure, and seizure control must be done prior to the gastric lavage. In gastric lavage, we are using potassium permanganate and copper sulfate solution to convert the phosphorus, the toxic phosphorus, to harmless oxides, which then followed by administration of activated charcoal and 30 minutes later by a saline catheter. And what are the precipitating factors? Fat favors the additional absorption of phosphorus, hence patients must avoid fat in diet for 3 to 4 days or longer. Mineral oil dissolves phosphorus and prevents its absorption, hence it can be taken orally. It is usually given at a dose of 1.5 ml per kg body weight. There is no specific antidote for yellow phosphorus. Close monitoring of hepatic and renal function should be done and managed accordingly. Liver transplantation has been successfully done in suitable candidates for acute hepatic failure. For liver transplantation, yellow phosphorus ingestion carries a grave prognosis unless treatment is started early. TP for yellow phosphorus poisoning comes under category 2 grade 2B, category 3 grade 2B. The mortality rate may be even high as 50%. Liver transplantation should be considered in suitable patients. Patients for liver transplantation are selected per King College criteria of King College London. And this is the criteria. The most common cause of acute liver failure is, we all know, paracetamol. Acetaminophen causes and non-acetaminophen causes. Arterial pH should be less than 7.3 or prothrombin should be more than 100 seconds. INR should be more than 6.5 and serum creatinine should be more than 3.4 mg per deciliter. Grade 3 or grade 4 hepatic encephalopathy. Non-acetaminophen cases, prothrombin should be more than 100 seconds. INR should be more than 6.5 or any of the three following. Age should be less than 10 years or more than 40 years. Duration of jaundice before onset of encephalopathy should be more than 7 days. Etiology: non-A, non-B hepatitis, halogen hepatitis, and idiosyncratic drug reaction. Intermediate serum bilirubin should be more than 17.6 mg per deciliter. INR should be more than 3.5. Prothrombin time more than 50 seconds. And this is the OSPHA guidelines for TP. We all know category 1, it is a first line therapy, either as a standalone, either as a primary standalone treatment or conjugation with other modes of treatment. And for second category, apheresis is accepted as a second line therapy, either as a standalone treatment or in conjugation with other modes of treatment. And third one is decision making should be individualized. Optimum role is not established. And 4, published disorders in which published evidence demonstrate or suggest apheresis to be ineffective or harmful. IRB ethical committee approval is desirable if apheresis treatment is undertaken in these circumstances. And these are all the recommendations in after category grading. And these are all my reference I took from to do the journal. Thank you.